So if you've been to some of these, the monthly programs that we're doing, we're trying to pick a topic each month and dive into it a little more deeply rather than sort of glossing over a whole lot of things. And tonight we're going to talk about pain. And so pain is sort of an interesting topic in multiple sclerosis, because if you go back in time, the old thinking was that multiple sclerosis was not associated with pain. And you will still run across healthcare providers who will say, if you have pain, it can't possibly be from your multiple sclerosis. And we know that that's not true. We know that pain is common in MS, and about half of people with multiple sclerosis do experience some sort of chronic pain. So we kind of give it a big, well, duh, I mean, now that we think about it. We're going to talk about 3 different types of pain in multiple sclerosis, and I'll go into these in more detail. We're going to talk about something called dysesthesias. We're going to talk about neuralgias, and we're going to talk about painful spasms and spasticity. And we should always remember that just because a person has multiple sclerosis doesn't mean they can't have other health issues. And so not everything that's painful in a person with MS is necessarily due to their MS. We always have to keep that in the back of our mind. Sometimes there's a tendency for, once you have an MS diagnosis, for everything that comes up in your life, for a healthcare provider to say, it's just your MS. MS can be, or pain in MS can be part of a much bigger picture. There are a lot of other things that can happen when you have pain. You can have depression. You can have altered sleep. You can have fatigue. You can have poor attention and concentration, and you can have deconditioning. And things get to be very circular after a while. Sometimes it's hard for us to know, well, what's driving what? Are you depressed because of your altered sleep? Are you poorly conditioned because you hurt? And sometimes when we think about managing pain in MS, we can jump in and treat some of these other conditions, and we may help that whole circle. So let's start with the dysesthesias. How many of you have heard the term paresthesia? So paresthesia just means an extra feeling. Sthesia means feeling, para means extra. So when you have altered sensation in multiple sclerosis, it's very rare that it's just plain old boring numbness. Usually it's decreased sensation and something else. Maybe it's a sensation of tingling, or there's water running down your leg when there's nothing there, or there's a crawly bug sensation when there's nothing there. If that extra feeling crosses over into the realm of being uncomfortable or painful, we call it a dysesthesia. And so dysesthesias can be burning hypersensitivity. Some people will say it feels like they've got a sunburn, so if something touches lightly, it's very annoying to them. Lhermitte's sign is sometimes considered to be a form of a dysesthesia. Lhermitte's sign is when you bend your neck forward and you get an altered sensation. Could be tingling, could be an electric-like zap going down your arms, your legs, your back. That's called a Lhermitte's sign. The MS hug, or banding, is a sensation usually like a belt around your chest or abdomen. It can be a form of a dysesthesia. It can also be a form of spasticity. And sometimes it's not entirely clear to us when someone says, man, it just feels like there's a tight belt around my chest or abdomen. We don't always know which is it. Is it spasticity or is it dysesthesia? If it's hypersensitivity to touch in a belt-like distribution, that's clearly a dysesthesia. Sometimes people with MS will come in and they'll say, I've got this band of sort of hypersensitivity, and if we didn't know better, we would swear that maybe it's the beginnings of a bout of shingles. If you have ever talked to someone with shingles, sometimes before the skin lesions actually break out, they get these bands of hypersensitivity. So if you ever think you're having an MS hug, but then it's followed by little blisters popping out on your skin, keep in mind that shingles can also cause this sort of pain. So what do we do for dysesthesias? Most of the medications that we use to treat dysesthesias can be broken down into one of 2 groups, either anticonvulsants or antidepressants. Sometimes we have to do a little bit of explaining and say, if we're putting you on an antidepressant for a dysesthesia, it may not necessarily mean because we think you're depressed. It may be because that's going to be a treatment for your pain. Earlier we said sometimes depression goes along with pain, and so sometimes an antidepressant may cover more than one base. So why do we use these types of medications? A lot of what anticonvulsants do in terms of preventing seizures is they prevent nerve fibers from having abnormal communication with one another. So when you think about a seizure, what a seizure is, it's in the brain, you get a little abnormal electrical discharge that then starts influencing its neighbors to participate in that abnormal electrical discharge. So then you get this spreading sort of wave of abnormal electrical activity causing a seizure. Well, that abnormal electrical crosstalk between naked nerve fibers is sometimes what dysesthesias are from. So the same way that these anticonvulsants work to prevent seizures, they can sometimes work to treat these dysesthesias. So Neurontin, or gabapentin, one of the most commonly used medicines. One of the great things about gabapentin is that it goes into your body, gabapentin, and it comes out gabapentin. It's one of the few drugs I can think of that has no metabolism. It's not broken down into anything else. It also doesn't interact with other medications. What's the downside to gabapentin? The dosing range is huge. So gabapentin comes in a 100 milligram, a 300 milligram, a 400 milligram, a 600 milligram, and an 800 milligram. And the dosing range is anything from 100 milligrams a day all the way up to 3,600 milligrams per day. Believe it or not, we used to take it higher than that. We used to take people up to 5,000 milligrams a day, and then it was shown that really after about 3,600 milligrams a day, your GI tract really can't absorb anymore. So we're putting more in your system and you're really not, it's not going anywhere other than in the toilet. We don't know in a given individual what the best dose is going to be, and there's a lot of playing around with the dosing. But other than that, it can be a good medication. Lyrica is something that we use commonly now for pain management and can be a great medication. Tegretol or carbamazepine, trileptal, oxcarbazepine can also be very useful for pain management. Antidepressants. We used to use a lot of amitriptyline and nortriptyline. These are very old antidepressants. To see an antidepressant effect with amitriptyline, we frequently had to get people up to about 150 milligrams a day. The problem with putting someone on 150 milligrams of amitriptyline is it's probably not going to matter if they're depressed because they're probably going to be asleep. It's really sedating. So we don't use that for depression anymore. We use it now mainly for pain management. So for pain management, we would use 10, 20, maybe 30 milligrams, usually just at bedtime. Amitriptyline and nortriptyline stick around in your system for a long time, so we can give it to you at bedtime. It's probably going to make you a little drowsy. So if you're having some sleep issues, it's going to probably help to get you to sleep. Then the hope is that it's going to stick around in the daytime and give you some pain relief. The problem is sometimes that drowsiness sticks around into the daytime also. So some people will sleep well, but then they feel hungover the next day. They feel kind of rummy and just not quite right. The other problems that we have to be aware of with amitriptyline and nortriptyline is they can be really constipating. They dry your mouth out, and in some people they rev your appetite up a little bit. So you can see weight gain with amitriptyline and nortriptyline. Cymbalta or duloxetine, newer medication. We love Cymbalta. It can be great for pain management, and there's not a lot of playing around with the dose. So typically we'll start 30 to 60 milligrams once a day, and the highest we usually will go is 120 milligrams daily. And then finally, Savella is another one of the newer antidepressant type drugs that we can use for pain management. So if you have a fairly small area of involvement, so what if you just have burning hypersensitivity in your feet, really just from the ankles down, or what if it's just a patch of skin that's really bothering you? Lidoderm patches, if you have a small area of involvement. Patches not so convenient to put on your feet, but if it's an area, say your shoulder, that's burning, lidoderm patch is just transcutaneous lidocaine in a little adhesive patch. It's worn for 12 hours on, 12 hours off. In the time that you don't have the patch on, those 12 hours off, you still have medicine in the system working there. Almost no side effects from that. So again, it could be a good option if you just have a small area of involvement. If you have a small area of involvement that's really not good for a patch, we have compounded topical creams that you can do. And if you go to an old-fashioned pharmacist where they still compound and make medications, they probably have a list of different compounded topical pain medicines that they can use, and they're just a bunch of different recipes out there. Usually it's some combination of gabapentin, lidocaine, clonidine, ketamine that they have. Like for our Shepherd Apothecary here, we have a list, and there are about 8 different topical medicines that we can put together for pain management. Sometimes you can put anti-inflammatory medicines, so if you were having some joint pain, you could put something that's an anti-inflammatory medicine. One of the downsides with these compounded topical drugs is that they're usually not covered by insurance. This is an off-label use when you start putting all of these ingredients together, and they're not inexpensive. They're about $200 a month for these medications. But again, if you're trying to avoid side effects of maybe taking an oral drug, this might be an option for you. So what about neuralgias? When we say neuralgia, we mean a nerve-type pain, and with multiple sclerosis, the two that we're most interested in are trigeminal neuralgia and occipital neuralgia. Trigeminal neuralgia is much more common in the MS community. It can be seen in people without multiple sclerosis. And trigeminal neuralgia usually is extreme facial pain, usually either along the cheek or along the jawline. The trigeminal nerve is a nerve that comes off of the brainstem, and it supplies sensation to your face. It has 3 branches, one for your forehead, one for your cheek, and one for your jawline. We don't know why, but we very rarely ever see the trigeminal neuralgia causing pain up in the forehead. Usually it's down in this region. People who have trigeminal neuralgia are usually pretty miserable from it. It's bad facial pain. It can be described as like an electric bolt hitting you. Imagine a bad tooth pain, like if a dentist hits a nerve with a drill. That sort of pain is what we typically see with trigeminal neuralgia. Occipital neuralgia is in the back of your head. The occipital nerve comes out of the base of your skull, and it supplies sensation to the back of your scalp. And what people with occipital neuralgia will describe as pain in this area, usually on one side, occasionally both, usually hypersensitive to touch. If you were to touch your hair, brush your hair, it's going to give you a very uncomfortable sensation back there. So trigeminal neuralgia management, we usually start with medications. Carbamazepine or Tegretol is probably one of the most commonly used drugs. Oxcarbazepine is a very similar medication. We also use phenytoin, which is a seizure medication, and some of the other anticonvulsants, lamotrigine, gabapentin, clonazepam. The thing that's tricky with trigeminal neuralgia is in some people it comes in waves. So some people have pain that will go on for a couple of months, and then they may go months without it. So in a lot of people, once we break the cycle of pain, the question is, can we stop their medication? Once we get this pain under control, many people with trigeminal neuralgia are actually afraid to come off of their drugs because of how bad the pain can be. So it's always a kind of a delicate balancing act between controlling the pain but trying to get people off the medications if we can safely. Injections, Botox injections have been used for trigeminal neuralgia, and then actually trying to deaden or damage the nerve itself with glycerol injections is also done as a treatment. Gamma knife procedure, again, is a way of potentially shutting down this nerve pain. Radiofrequency lesioning. When I was in medical school at the University of Florida, this was the most commonly done neurosurgical procedure at Shands Hospital in Gainesville, was called RIFL, radiofrequency lesioning for trigeminal neuralgia. Again, it's a way of permanently damaging that nerve to shut down this nerve pain. The exchange is you may end up with some numbness in the area of skin that's supplied by that nerve, but most people with trigeminal neuralgia would say, that's a good trade. I'll take a little numbness in exchange for pain control. And then finally, decompressive surgery is something that can be done. There used to be a thought that everyone with trigeminal neuralgia had a blood vessel in the back of the brain near where the trigeminal nerve was that was actually butting up against that nerve, and that what was happening is that as that blood vessel pulsed with a normal heartbeat, that it was irritating that nerve. So a surgeon years ago, Dr. Janetta, said, I bet if I went in and I put a little cushion between the nerve and the blood vessel that I would relieve the pain, and it's called a Janetta procedure. And for a lot of people, that does work. Well, with multiple sclerosis, we think the problem is actually from your MS lesions in the brainstem, not from a blood vessel bumping into it. But for reasons we're really unclear of, this decompressive surgery does work for trigeminal neuralgia in people with MS. And physiologically, I can't tell you why it would work. Emory University here in Atlanta has a really good track record for many of our patients in treating trigeminal neuralgia. It's not something we want to go to as a first option. Ideally, we'd like to find a non-surgical treatment if we can. But if a person's quality of life is really suffering, this is certainly a good option. So what about occipital neuralgia, the pain back here? All of the medications that we mentioned earlier for treating the trigeminal neuralgia are also in play for occipital neuralgia. Interestingly, there's an old anti-inflammatory medicine, indomethacin or Indocin, and for reasons, again, we're not entirely clear on, indomethacin can be a great treatment for occipital neuralgia. It's 50 milligrams twice a day. It can be used on an as-needed basis. You want to have some food on board so it doesn't upset your stomach, but we usually know pretty quickly if indomethacin is going to work out for a person for occipital neuralgia. And then what the diagram is showing here is an occipital nerve block. The occipital nerve is very superficial, and all it does is supply sensation to your scalp. It doesn't supply any muscle or any visual function, so you can go in with lidocaine and some steroids and do a local block on that nerve. Again, very superficial. Our Pain Institute does this frequently. And when it's successful, you may buy the person 3 to 6 months of pain-free time with an occipital nerve block. So we're going to shift over. Let me see if I can get rid of that little dot down at the bottom there. We're going to shift over now and talk about spasticity and spasms. So when we say spasticity or spasming, what do we mean by that? So there's a normal balance in the human body between muscles that want to flex and muscles that want to extend. In general, what your brain wants is for the arms to extend and for the muscles and the legs to flex. If you take away the brain's influence from those muscles, think about someone who's had a stroke. What do they look like in terms of their muscle tone? They tend to carry the arm like this and the leg is stiffened out. That's because you've now imbalanced between what the brain wants the muscles to do and what the spinal cord wants the muscles to do. Well, multiple sclerosis can put lesions in the brain and spinal cord and change this normal balance between flexor muscles and extensor muscles. So what we tend to see again in multiple sclerosis is we tend to see extensor spasms in the legs and flexor spasms in the arms. So when we talk about spasticity versus spasms, spasticity is when the muscles are chronically too tight. If you have chronic spasticity that's not treated and it's severe, you end up with contractures. So this is the person whose muscles are tight and now the tendons have actually shortened because those muscles are chronically tight. If you don't do something about spasticity early, you can end up with tendons that have to be surgically lengthened and loosened up. Spasm is a wave of too much muscle tone. So if you're lying in bed and all of a sudden you have this sudden wave of increased tone in your legs, that's a spasm. So when we talk about spasticity, we just make the automatic assumption that all spasticity is a bad thing, but not all spasticity is bad. If you have increased extensor tone in your legs and your legs want to straighten out, some people with MS are actually using that extensor tone to help function. They may use that extensor tone to help with transfers, so when someone stands them up, the legs want to stiffen out a little bit. They're actually using that to do a stand pivot when they're transferring. Some people use too much extensor tone to actually help walk. So if you've got weakness in your legs, you might actually use a little bit of that spasticity to compensate for the weakness. In most people with spasticity and spasms, we can get rid of all of those spasms and spasticity. Sometimes when we do that, we make people less functional. So one of the things I like to do early on with MS is get people involved with a physical therapist for them to give us some guidance on how much of the extensor tone in the legs the person might actually be using to help function. So if we take away all of your tone, you might look like the chickens on the boneless chicken ranch. You're just kind of like a rag doll, and we don't want you to be a boneless chicken, unless you're from Chick-fil-A. So when we think about managing spasticity and spasms, there's sort of a graded way that we do that. The first, we don't automatically jump to our prescription pad. One of the things that we want to do is think about getting rid of noxious stimuli. So when we say what's a noxious stimuli, something that's irritating. So things like ill-fitted shoes, clothing that's too tight can actually make your spasms kick up. So that we try to get rid of, if you have, say, again, shoes that aren't fitted correctly. We're going to have people be aware of that. Underlying infections, probably one of the #1 causes of increased spasticity. If someone calls into our call center and says, I was cruising along doing okay and now my spasticity has just gone nuts all of a sudden, do you have an underlying bladder infection? Do you have an upper respiratory infection that's causing that? So we've gotten rid of your noxious stimuli. Now we're going to move up to the next level if that's not doing it. We're going to start looking at rehabilitation, exercise, stretching. So if you're not in a regular stretching program and you have painful spasms or spasticity, whether we do this through a physical therapist, whether you come here to the wellness program and you're doing yoga or whatnot, that's one of the things we want to do. We want to keep you moving. Most of you will say the longer you sit or when you first get up in the morning, the worse your spasticity is. So, when we look at a person with MS going on a 8-hour car trip or on a plane ride, we can pretty well bet when they try to get out of that car or get off the plane, they're probably going to be pretty tight. So movement is one of the important keys. Physical therapy. Occupational therapy, and the physical therapist and occupational therapists kind of divide our body up. The occupational therapists get most of the activities of daily living or things that involve fine finger movements. If you tend to have flexor spasticity in your hands, so you're wanting to do this, one of the things that occupational therapy is going to do is get you some hand splints to stretch those fingers out at night so that it's a way of getting some range of motion through splinting. So now we've gotten rid of the noxious stimuli, we've got you involved with physical therapy, you're doing your stretching program. What if that's not enough? We're now looking at medications for spasticity. Our old standby, it's been around forever, is baclofen. Baclofen is something that we use frequently. Baclofen is, again, can be a great tool, but we have to be careful with it. If we give you enough baclofen, we know we can probably get rid of most of spasticity and spasms. We also may make you really, really drowsy, and we also may make you a rag doll, so that baclofen may sometimes cause weakness. Xanaflex has been around for a few years, and I would say that's kind of the counterpart to baclofen. It works very differently from baclofen. We do sometimes use them together because they may hit the problem from a different angle. One of the things we have to be careful with tizanidine is your blood pressure. Tizanidine molecularly is very close to clonidine. Clonidine is a blood pressure medication. It's designed to lower your blood pressure. That's not what we're trying to do with tizanidine, but occasionally it will drop blood pressure just a little bit. So when people first start tizanidine, if they're going from a lying to a sitting or a sitting to a standing position, tell them just be careful, make sure that your blood pressure is not dropping, that you're not going to get lightheaded and pass out. Benzodiazepines is the molecular name for the group of drugs including Valium, clonazepam, Ativan. These are great muscle relaxants. We have to be a little bit careful. They all have some addictive potential. We tend to use more clonazepam because it sticks around longer. When you look at drugs that people tend to get tolerant to or addicted to, they usually are drugs that get into your central nervous system quickly and get out very quickly. So think about things like methamphetamine and heroin. These are things that get into the brain really quickly and get right back out. Clonazepam is the longest acting of the benzodiazepines, so it has the lowest potential for addiction or tolerance. Typically can be used as a twice-a-day medicine. If you're having a lot of trouble with spasticity or spasms at bedtime, interrupting your sleep, clonazepam can be a good bedtime option because it's going to make you a little drowsy and it may help with your muscle tone throughout the night. Dantrium is an old medication, and again, for reasons I don't really understand, it seems to work really well in people with spinal cord injuries who have spasticity. I'm not as impressed as what it does for multiple sclerosis. One of the tools that we take advantage of here is if we in the MS side are having a hard time getting control of spasticity, we may refer you over to to one of our rehabilitation doctors, and they do use a lot of Dantrium still. Frequently, the reason we're referring you over there is to talk about another more aggressive treatment, which we'll get to. Some of the anticonvulsants, like our gabapentins, can also be used for treating spasms and spasticity. So what are some of our other options? And this is usually where we're referring you across the hall to the rehab docs. If you have focal muscles, one or two muscles that are just really giving you a hard time and we can't loosen those up, again, Botox injections may be something that we can use. We can't use Botox injections in muscles that you're using in your daily routine, because what we're trading, when we control your spasticity with Botox, we're trading that for weakness. Botox is designed to paralyze the muscle. That's how it works. So if you have a muscle that you're relying on, we probably don't want to do Botox on that. Botox is typically going to last about 3 months until it wears off and you'll come in and do another injection. What about intrathecal baclofen? So the picture shows a baclofen pump. These are pumps that are inserted surgically under the skin. There's tubing then that delivers concentrated liquid baclofen into the spinal fluid. When we give you baclofen by mouth, it's going into the GI tract, it's going into the bloodstream. A certain amount of it gets metabolized by the liver and sort of taken out of the system. A certain amount of the baclofen actually crosses into the brain itself. That's not where we want baclofen working. If you're getting drowsy from baclofen, it's because of the baclofen that's actually gotten into the brain itself, and that's not where it's designed to work. It's designed to work in the spinal cord. So what if we could just bathe your spinal cord in concentrated liquid baclofen? That's what a baclofen pump does. So in the right person, a baclofen pump can be wonderful. The key is getting the right person. And so there's a process that you go through before you would think about a baclofen pump. It's a big deal. You're having a surgically implanted pump. It's got to be refilled, typically on an every 3, maybe out to an every 6-month basis. So you've got to come in and get that done. The pump itself has to be replaced every few years. So it's not a small undertaking. Usually now, when we think about a baclofen pump trial, that's done in one of 2 ways. We want to make sure that you're going to get what you want and expect out of that pump, so they can actually do a one-time test dose of baclofen into the spinal fluid, and that's going to be like a spinal tap, but they're going to give some of the baclofen to see if it does what you want it to do. Or they can do a trial pump. With a trial pump, they're hooking you up with a temporary pump that's not actually surgically implanted. It's on the outside of your body. And then they're going to let you wear that for 24 hours to see if it does what you want it to do. So the baclofen pump, again, something in the toolbox to think about. Probably not what we're going to go to as our first option, though. We're going to shift now to a topic that probably a lot of you have thought about, and that's cannabinoids and multiple sclerosis. So cannabinoids are the generic term for the chemicals in the marijuana plant. There are 500 cannabinoids in marijuana. The 2 that we tend to talk about most in regards to multiple sclerosis are THC and cannabidiol. THC is the part of the marijuana plant that makes you high. If someone says, I like using marijuana recreationally, they're probably getting a THC effect. Cannabidiol is the cannabinoid that is most effective for central pain, that means pain coming from the brain or spinal cord, and for spasms and spasticity. So the cannabidiol tends to not be psychoactive. It's not going to typically make people high. So what does the American Academy of Neurology say about this? The Academy of Neurology will look at all of the published trials, research that have been done in different things, whether it's a drug for epilepsy or in this case cannabinoids, and they came out with 2 statements. They said that there was strong evidence that oral cannabinoid extracts reduce the patient-reported scores of spasticity in multiple sclerosis. And they also said there was strong clinical evidence that oral cannabinoid extracts are effective for reducing central pain and spasms in people with multiple sclerosis. So there is science out there that says that these things can be useful. So where are we at right now? And I would say our discussion here in Georgia is going to be a different discussion than someone in California is going to have. Each state in the union has different laws or no laws. So currently there are 23 states in the union that have legalized medical marijuana, the plant itself. And if you Google state-by-state laws on medical marijuana, you'll find the state laws, and they all vary tremendously, and what that process looks like and what health conditions are included. I will say in states that have some sort of law on cannabinoids, multiple sclerosis is included in all of those states. So I think it's uniformly recognized that if you're going to look at cannabinoids, that multiple sclerosis is something that should be on the list that can be potentially treated in terms of pain or spasticity. Georgia passed in 2015 our low THC cannabidiol oil law. And what the law says is that if you have multiple sclerosis, that your healthcare provider can put you into the registry so that you would be able to legally possess up to 20 ounces of a low THC cannabidiol oil. We got a couple of surprises when they actually opened the registry up. Through the legislative process, nowhere in the process did we hear them specify kind of what type of MS. But when the registry opened, they added two things: severe MS or end-stage MS. End-stage MS means you're dying from it, and hopefully that's not a tremendously common occurrence. Well, what does severe MS mean? And I think that's where things are open for discussion. If you go to healthcare providers who work with MS and you say, well, who do you think would be a candidate to be put in this registry? You're probably going to get 100 different answers, because there is no legal definition or medical definition of what severe MS is. I can tell you for me personally, and this is not Shepard's stance, this is just me, I would say you would have spasticity or spasms from your multiple sclerosis. They would be significantly affecting your quality of life, and you will probably tried at least two standard options, probably baclofen and tizanidine, that you have tried these things out and that these things have not worked for you. Cannabidiol is not a miracle. It is not a cure. There is a question, and there's research going on as to whether cannabinoids actually affect the immune system in a positive way for autoimmune conditions or for cancers, but I don't think we have the answer to that. So when we think of this, of the cannabidiol oil, we think of it as a tool in the toolbox for helping manage pain from your MS or spasticity and spasms from your multiple sclerosis. So that's kind of where I see it fitting. So what's the other problem that we have right now with the current law? So if you meet those criteria and I sign you up and I put you in the registry, the Georgia Department of Public Health is going to contact you and say you can come pick up your card. There is no dispensing mechanism in the state of Georgia. There is nowhere to go to get the oil. And so that is what our legislature, as we are here now in 2016, this is something they're grappling with right now. There is a task force that meets on a regular basis and is trying to work through this. The last vote that the task force took, I believe it was in December, they decided to not allow cultivation of marijuana in the state of Georgia. So that kind of, they didn't say they wouldn't in the future, but at that time they didn't feel like they were ready to go there. So where does that leave us? Well, if the oil can't be shipped across state lines and the state says you can't grow it in the state, is there a marijuana ferry that's going to come down and magically, we don't know. So hold on for just a second. We're going to come, because I know there's going to be a lot of questions on this, and we'll come back to this and spend some time. I don't want to go into too many specifics about specific places, and this may be where your question. There are places out there that are manufacturing cannabidiol oil, CBD oil, and it is definitely the wild, wild west out there, because it's not like these are FDA approved products. It's very hard for a healthcare provider to give you sound advice and say, you should use this one and not that one. So we're learning along with you guys. I would say definitely buyer beware. There are scam companies out there, and the FDA has sent out warning letters to several of these companies. You can go down to, Little 5 Points in Atlanta and go to some of these stores that are selling CBD oil $50, $60, $70 a bottle, and it probably has no CBD or very, very little in it at all, and is probably going to do absolutely nothing. So it is a little unsettled right now. We don't know, how to get there. 2 seconds. I'm going to get right back to you. I'm going to finish up with one last slide, and then I'm going to throw it open to Q&A because I know this is a hot topic for people. I would finish up by just reminding you that not everything that causes pain in a person with MS is due to their MS. This is a very difficult medical case that came up, but I want you to put on your doctor hat. See if you can tell me what is causing this guy's pain. Doesn't. Could be the nail that's driven through his skull, and I'm going to go out on a limb here and say that that's probably not an MS-related pain there. I think it's the nail in his head. Very good. Thank you guys very much. Be careful going home.